everyone to our noon Facebook Live here at Memorial Healthcare System. I'm Yanette Obario Sanchez, and I am your host for today. And I want to welcome everyone to Don't Miss a Beat when it comes to your heart health. So, if you are looking for some information about heart health, you've come to the right place. I want to, as we do with all of our lives, we want to encourage you to tag a friend or a family member below. You can also share this link with folks that might benefit from this. If you don't get to do it now while it's live, it's okay. It will be here, live on Facebook and on YouTube, and you'll be able to catch it later. Um, why are we talking about our hearts? All right, so it's Heart Month. I'm wearing red. Many of us are, and we're celebrating our hearts because our hearts work so hard. They beat about 115,000 times a day, and they pump about 2,000 gallons of blood every single day. So, however, the bad news, right? So there's always good and there's always a little bit of bad. Unfortunately, heart disease is the leading cause of death for men, women, and people of most racial and ethnic groups in the United States. So I hope you heard that right. This affects all of us. We all have a heart, and we really should be looking into this. But don't worry, I have a couple of our amazing doctors with us today to tell us a little bit about what they do. We start things off with Memorial Primary Care, and I want to introduce Dr. Helen-Valentine Chukwu, internal medicine physician with Memorial Primary Care. And we have Dr. Ralph Levy, Chief of Adult Cardiac Services at Memorial Cardiac and
Yep.
Vascular Institute, together here to discuss some heart health. Hi, doctors. Welcome to both of you.
Good afternoon. Good to be here.
Thank you so much. A pleasure to be here.
Thank you both for joining me. So, as we continue, every once in a while, I'll stop and say, "Hey, guys, you can leave us a comment, leave us anything that you like to discuss, and also remember tag a friend. Really important." We're gonna kick things off with primary care. So, Dr. Chukwu, as a primary care physician in general, how often should we be seeing you?
This is a question that a lot of my patients ask, and it's a really important question. For example, if you're over the age of 20 and say you notice that your blood pressure runs less than 120 over 80 regularly, then it's reasonable to at least make sure that you're seeing your doctor once 1 to 2 years. If the blood pressure runs higher than that, it's likely that you're going to have to see your doctor more frequently. So this is important. Just standardize that annual exam with you and your doctor. Now, this is Heart Health Month. Let's talk about modifiable risk factors, things that we can do to decrease that risk of having cardiovascular disease. What does that look like? Blood pressure monitoring, cholesterol monitoring blood sugar intake so you don't develop diabetes. How can we do this? Diet, exercise, a holistic approach, merging the two. It's really important that you have that honest conversation with your doctor because based on what you're eating, if there's any type of drug consumption, medication that you are taking, all of these factors can impact your heart health.
Thank you, Dr. Chukwu. And Dr. Chukwu, when you go to your primary care appointment, what does a heart exam look like? Does this involve blood pressure? Does it involve an EKG? What should we expect on our annual exam?
You know, that's really interesting because believe it or not, the heart check begins even before the doctor comes into the room. What do I mean by that? Well, before one enters the room, you're going to look at the vitals. So we'll be looking at the heart rate. Remember, if a heart rate's a little bit elevated, 120s to 140s, that's a bit concerning. And if you're at rest, so that heart check is beginning at that point. Not only that, you're looking at the respiration rate. When you do enter the room, you're taking things from an observational perspective. For example, you're looking at the neck veins. Is there any neck vein distension? If you see that, that could be a sign that something's going on in the heart. Furthermore, you look at the extremities. Is there any swelling. If it's seen, that could be a sign that something's going on with the heart. We then proceed to physically listening to the patient, assessing the patient. We listen to the heart rate. Is it regular? Is it irregular? Do we hear a murmur? These could be signs that something is going on with the heart. So this exam begins from before we even enter the room to before we even physically touch the patient, to when we listen to the patient, and we get a full history and family history as well.
Thank you for that. And as you're saying about family history and screenings, I wonder, when do you, as a primary care physician, know or you feel that it is time for this patient to see a cardiologist, to see Dr. Levy or Levy, English or Spanish, Dr. Levy and his team at the Memorial Cardiac and Vascular Institute?
So identify when a patient should see a specialist. It involves quite a few things. You're looking at symptoms, you're looking at lab results, you're looking at family history. For example, if there's early family history of coronary artery disease under the age of 40, is the person's blood pressure significantly elevated? And that's also seen in combination with symptoms of chest pain, shortness of breath, and an abnormal EKG. I'll give an example. Just last week, I had a patient came to the office, blood pressure was 220 over 120. They had symptoms of headache, chest pain, and abnormal EKG. With symptoms like that, that patient needs a cardiac evaluation. Furthermore, they had been out of their medication for months, but they decided that day they were not feeling well, so they needed help. So we did everything possible to make sure that they got that help and got that cardiac assistance.
And that's incredible. And before we kick it off to Dr. Levy, there's something here that, as a patient myself, I think is extremely seamless in communication. Because when your primary care physician at Memorial talks to one of your specialists, right, when they know that you need to see both, as a consumer or as a patient, you see my chart. You use your my chart to see everything that you need to see. So you see what you did in your primary care physician office, and then your cardiologist will also add their information there. So it is such a seamless tool. So I encourage everyone, if you do not have your my chart, please sign up for it. It's on our website, mhs.net. And it's going to be amazing because it's such a great info, and you can contact your doctor, you can ask questions. It's really a great way to connect with both your doctors, because now when we're talking about primary care, now we're going to talk to Dr. Levy over in cardiology. Hi, Dr. Levy.
How are you?
Good, good. So for you, we have a couple of rapid questions that we are seeing that these are the top search terms um, on the internet. And we said, let's talk to Dr. Levy about some of these. Some of these include cholesterol, good, bad, or both.
Okay, so I have about 50 minutes to talk about this, correct?
Yes.
So kidding aside, cholesterol has been kind of the most important issue that we deal on a practice day to day. Patients are concerned about it, yet they're reluctant to take medications. Cholesterol is a very important compound in the daily running of our bodies. It's part of our cellular structure, particularly the membranes in the cells. So it's a crucial compound. Yet when we have an excess of cholesterol, it can be deleterious as well and can deposit itself in the arteries of our hearts or in the arteries that go to our brain and puts us at risk for both heart attack and stroke. I'll tell you a funny story. I had a chance to review recently the medical records of a patient who came from outside the country and who has had heart disease for a good 25 years, if not 30. And when I reviewed those records 30 years ago, cholesterol is not even mentioned, even though he was having heart attacks. And as I followed the records along, I could see that the trigger for treatment of the cholesterol changed in front of our eyes. And what we thought was a normal cholesterol 20 years ago, now it's considered to be a very high cholesterol. It turns out to be that this type of cholesterol called LDL cholesterol, which is what we call bad cholesterol, is indeed not only bad but useless to us. So driving that cholesterol as low as possible is now the dogma for us. We strive to do it. We have plenty of medications to do it. And the idea or the promise of this is that if you have never had a heart attack and we reduce your cholesterol to a certain level, the chances of you having a heart attack are very, very small. And if you already had a heart attack or a stroke, then we're going to be much more aggressive. One of the things that I tell to patients is that when we are born, our level of bad cholesterol, the really bad one, the LDL, is around 60, 40 to 60. By the time we turn 18, we have something called acquired cholesterol, which doubled that to around 120. In these patients that already had a heart attack, I'm going to strive to bring that bad cholesterol to 60. I'm going to make them like a baby again. I want that cholesterol to be the same as when they were born. And that will result in a much lesser chance of having another heart attack or a stroke. And if you've never had one, we're going to try to bring it to at least less than 100. But in these days, we also want to be low. The lower we go, the more protection you're going to have. We should not be afraid of lowering cholesterol. It's going to result in good things for us. There's an epidemic of heart disease in this country, and treating cholesterol is foundational in resolving this problem.
Thank you, Dr. Levy. And when it comes to cholesterol, some people say genetics has a lot to do with it, and some people say nutrition can also have something to do with it. Can you tell us genetics versus nutrition, what you see in cholesterol?
Absolutely. So we know that we have genetic abnormalities that predispose us to high cholesterol, very high cholesterol. They're called familial hyperlipidemias. That's a medical term. It means that it's not your fault that your cholesterol is high. It means that it's your genes that you inherited that are making sure that this cholesterol is super high. For those patients, again, we don't wait for them to have a heart attack. We don't wait for them to even have plaque in the areas of their heart because we know they're going to get it. Just as said before, that our normal cholesterol is 60, the bad one when we're born. These patients can have LDL cholesterol of 200 when they're born, and that is gonna result in them having heart attacks at a very young age. I have seen patients having heart attack in their 20s and 30s when they have this type of abnormality. So we treat those patients very aggressively. And of course, nutrition is crucial for us. I mean, we live in the United States, the land of oversizing things, from our, hamburgers to our drinks, et cetera, et cetera. And what we're seeing is, unfortunately, an epidemic of obesity in this country and an epidemic of diabetes, both of which are intimately associated with the risk of having a heart attack. So having a good diet, a responsible diet, one that allows us to live happy lives in good shape without any of the bad consequences of gaining weight or being obese is crucial for us as well.
And with that, you mentioned obviously nutrition is important. And then I wanted to talk about exercise. How often? What do you tell your patients? And what's the best exercise for our heart?
Okay, so I think that any exercise is good. Okay, yes, if you are in your apartment and you haven't walked in a long time, you're in front of your computer, just stand up every hour and walk for 5 minutes. If you are in better shape or you can go outside, our recommendation is a total of 150 minutes. That's 150 of moderate exercise a week, or 75 minutes of really aggressive or high intensity exercise a week. I can tell you that in Europe, the European Society of Cardiology doubles those numbers. It's at least 300. My answer in general is the more you can do, the better. Try to be active. When you're active, particularly as you get older, will allow you to lead lives in which you continue to live independently. You won't have to depend on anybody. It leads to less chances of having falls, for example, which are devastating. Exercise makes you feel good. It alleviates a lot of things. It makes your blood pressure lower. It makes your cholesterol lower. So, exercise is this free pill that is wonderful. We should all avail ourselves from this. You don't pay anything for this, and yet it's better than many of the medications that we take.
And on average, when we are exercising, should we look at our heart rest rate versus our heart rate during exercise?
I think for most people that is not really necessary. However, if you're concerned, what we mention to people is that we want them to have a maximum sustained heart rate of about 85% of what we predict the maximum heart rate should be. So all you need to remember this is the number 220. 220. If you subtract your age from that and you take 85% of that, that is the average rate you have sustained. Some people are going to go higher than that. Some people are unable to reach it. I don't want to get fixated on this. I want people to just get out, start walking, go to an elliptical machine. Swimming is an incredible exercise. It's both aerobic and resistance. It can be a stationary bike. Any exercise is good. Being sedentary is not. We need to get off our chairs and start moving.
All right. Thank you so much for this. And with that, I want to lead. And well, you talked a little bit. I don't know if you wanted to add anything else about nutrition. We've talked about healthy weight. We talked about. Is there anything that you wanted to add on that, or we can move forward?
What I would like to say, Helen, if you just forgive me for a second, I was talking to a group of physicians today about the issue of obesity, and I don't want to let go of that because it's one that is fraught with a lot of implications. It's a very difficult conversation to have with patients. It's a very difficult conversation to have with families. It's one in which I feel that physicians have failed their patients through the years. We only have so much when a patient comes to talk to them about their issues that bring them to the office. And when they ask us what to do about the weight, we give generic answers. And I think that that's something that we have to change both as a profession and a society. Right now, we estimate that about 60% or so of the United States inhabitants are overweight, and probably a good 15-20% are obese already. And that is bound to continue to increase as we go along. That's what we have seen in the incidence of obesity in this country. There's a direct relationship between obesity and most of the cardiac problems that we see, from an arrhythmia called atrial fibrillation to having a heart attack to having something called heart failure to non-cardiac complications of something called sleep apnea to arthritis to immobility. Patients who are obese don't feel good about themselves. There's all kinds of issues. I think that as a country and as doctors, we need to do better than that. It's something that we need to emphasize. We need to bring this issue from a forgotten issue to be the main protagonist. Unless we change this, doctors like me will be busy forever. I mean, we'll always have patients. My goal is that you never have to come to me, that you stay with Dr. Chukwu because you're doing fine, your weight is fine, you're exercising, you're doing well. And I think that will be my most important issue today.
Thank you for that. And Dr. Chukwu, did you want to chime in on something before we go to the next question?
Yes, I wanted to state that prevention is key. As Dr. Levy stated, the most cost-effective use of our time is diet, exercise, everything that is free. But for some reason, not everyone is taking advantage of that. We're all looking for a magic pill or a magic diet when the answer is literally right in front of us. It's a matter of being motivated, having a group of friends, family that can help motivate you, to help you sustain that continuity of exercise and healthy living. So it's about managing that healthy lifestyle. So that's what we really need to highlight. Now, I did mention the modifiable risk factors, the hypertension, the high cholesterol, the diabetes. Studies have shown if you decrease your total cholesterol level by, say, 10%, that can show an improvement or a decreased risk of heart disease by 30%. That decreases it by 30%, which is pretty significant. But we really need to emphasize, all of us together, the thing that is free for us all: good diet and exercise. That's what I'd like to highlight.
Thank you so much. Thank you so much. So with that, we're going to open up some questions to both of you. And I'm taking some notes as you guys are writing because, I'd like to keep these in my back pocket. So questions for both of you. Here we have one that comes up regularly. Do heart health supplements work? And what's the difference between statins and supplements?
Okay. Well, I will answer this. I will say this. There was a study that took place by the Journal of American College of Cardiology. And interestingly enough, when they looked at the statin medication, for example, rosuvastatin, and compared it to other type of supplements, looking at omega-3 fatty acids, vitamin B6, niacin, they actually found that hands down, low doses of rosuvastatin actually decreased a person's cholesterol by 30%. It showed a tremendous improvement in a person's risk of cardiovascular disease. However, the supplements did not at all. So what did this show? It shows that yes, there are some studies that show that, well, if a person has a negative vitamin B12 presentation, are they having increased risk of cardiovascular incidence? That was an association, but not necessarily a causality. But it did show directly that when a person is at that high risk, the statin medicine does save lives. It does save lives. So, like I stated, we can all look for this magic supplement, this magic pill, but let's focus on prevention so we don't necessarily have to get to the point where we're using statin medications. And let's do our best to emphasize the diet that is low in saturated fats, which is anything that's a solid at room temperature, and low in trans fats as well.
Thank you for that. Thank you for that. And Dr. Levy, did you want to chime in?
Not only to say that I completely agree with Dr. Chukwu. This is one of the things that patients always ask. They come with a list of 20 different supplements, and yet they tell me, I hate taking medications. When, as Dr. Chukwu mentioned, taking these medications, particularly statin drugs, does decrease the risk of heart attack substantially. So I think that our focus should be not, oh my God, I'm taking a medication. Our focus should be, I'm at a certain age, I'm at risk of having a heart attack. I don't want to have a heart attack. I don't want to have a stroke. Those things are devastating. What is my best strategy to do so? And the best strategy is, as Helen mentioned before, is correcting those risk factors we can correct. They're called modifiable risk factors, such as making sure your blood pressure is okay and making sure that your cholesterol is as low as it can be.
Thank you for that. And modifiable risk factors. There's one thing, and we have a question from Facebook that I wanted to interject because I know I was thinking it, because if I don't sleep, nothing happens. So I know we talked about exercise and we talked about nutrition. How important is sleep? I want to interject because we got that from Facebook.
Sleep is very important. Let's even go back to exercise. When you do that regular exercise, that helps maintain your cortisol level, which will help you sleep. So there is an indirect correlation. Make sure you're getting about 7 hours of sleep daily. Turn off the things that may trigger you and prevent you from getting that REM sleep, such as blue light, anything such as a TV, cell phone. Please make sure that you're turning those things off. You really don't want anything to stimulate the brain and be a hindrance to prevent you from having that restful sleep. Now, as Dr. Levy mentioned earlier, you can start slowly. Make sure that you try to achieve your target heart rate, 150 minutes of exercise weekly. You can make sure that you get 30 minutes of speed walking to your target heart rate. We talked about the calculation of target heart rate. Take that number 220 minus your age. Take 85% of that number. That's the heart rate that should be maintained for 30 minutes in order to keep that good cholesterol, that HDL, elevated above 60 to protect you from a heart attack and stroke. So when that is done regularly, that regulates your cortisol level. It helps you sleep better. It helps you produce natural endorphins. This is a win-win situation for everyone. Sometimes people will be looking around you. They'll be asking you what pill you're taking. But you're taking the exercise. You're just exercising. And that is for free, available to all.
Thank you for that. Thank you. Thank you. I wanted to go to our next question. And we have, this comes up all the time, trending, COVID and the heart. Having COVID or having the COVID vaccine And I wanted to start this one off with Dr. Lee.
Yeah, you're right. We get these questions every time. I can tell you now that unfortunately, something we have to deal with throughout the pandemic. The amount of disinformation out there is astounding. Um, I want to deal this from a scientific point of view. I certainly don't want to get into the politics of this. What we know is that number one, vaccines are extremely safe. Number two, we know they have saved countless lives, probably many, many dozens of millions, and they have prevented also many, many complications. As any other intervention, you know, vaccines can have issues. And when I say any other intervention, for example, I propose that you go for a surgery. You know, when you go for a surgery, for example, we're going to have to mention to you, we're going to want to mention to you the possible complications of the procedure. When we give you a medication, we mention to you the possible side effects of the medication. The COVID vaccine is no different. And one of the signals that we were able to observe was the fact that a very small number of patients actually got something called myocarditis, which is inflammation of the heart. But the numbers are incredibly small. Something about 300 cases out of 7 million vaccines. The number of cases like 0.003, I believe, of 0.00 is 3 zeros and a 3. So the chances of anybody getting myocarditis because of the vaccine is extremely remote. Not only that, but the cases of myocarditis are mostly relegated to young men between 25 and the ages of 25 and 40. And invariably, these men tend to recover. Now, let's think about the opposite. Like any other virus, the COVID virus can cause myocarditis, can cause inflammation of the heart. The chances of you getting myocarditis because of COVID is 11 times higher, 1,100% more than the risk of the vaccine. So if you put in a scale the dangers of the vaccine and the benefits of the vaccine, there's no question that the vaccine is safe, well tolerated, and it has helped a lot of us, including myself, go through this pandemic unscathed and be happy and be healthy. So I would urge you, particularly if, as predicted, we're gonna maybe have to get a COVID vaccine once a year. I would urge you to get it. Just as I would urge you to get the flu vaccine, for example. Many of you don't know, but there is a direct relationship between getting the flu and having heart attacks. It has to do with something called inflammation in our bodies. So I urge all my patients to get the flu vaccine once a year as well. The only other issue with COVID that is important is something that we are seeing. Is something, and this is a very long name, I apologize to you guys, it's called autonomic nervous system dysfunction. Just let me put it in lay terms. We all have a nervous system in our brain that controls all the things that we don't think about, like walking or our hearts beating or our lungs working, our intestines, our stomach. Sometimes that can go haywire. And I have patients who have symptoms of rapid heart beating or excessive lowering of the blood pressure after having COVID. Usually, that is self-limiting. Most of these patients get better. So it doesn't appear to be a long-term problem. Other than that, particularly with the latest iterations of the virus, we are seeing much less myocarditis than before. So from the point of view of the heart, we are much more optimistic from that point of view.
Thank you for that. Dr. Chukwu, anything to add there?
Well, just as Dr. Levy said, the studies show that before people got the vaccine, they were at 11 times more risk of developing myocarditis. If you look at their positive rate within a 28-day period. But when they got that first dose of the vaccine, that risk of developing myocarditis was decreased by half, which is significant, decreased by half. So it's a very small portion of a population that we're seeing with this. And taking the vaccine highly outweighs the risk of the development of myocarditis. So I strongly urge my patients to be protected, to take the vaccine in order to obtain that protection. Because not only are you protecting yourself, but you're protecting your neighbor, grandparents, elderly population, people who have cancer on immunosuppressive medications, you're helping a whole population.
Thank you. Thank you so much. And Dr. Levy talked about flu shot, and I can see primary care physicians everywhere rejoicing because I know you guys always talk to us about the flu shot. So great plug there, Dr. Levy, for the flu shot. Um, we have a couple more questions, and we're wrapping up. But this one's important: pregnancy and how it affects the heart. I throw it to either of you because I know that this is important.
Yeah, if it's okay, Helen, I'll take this one at the beginning and you can comment as well. Right now at Memorial, we have started a program called cardio obstetrics because we thought this as a huge issue. We know, for example, that cardiovascular disease is the leading cause for mortality in the United States. In spite of us being a developed country, we have seen an actual increase in maternal mortality. This in part is because women having children at a more advanced age, there's an increase in things like hypertension and diabetes. We have had, we still have persistent racial and socioeconomic disparities to lead to poor care of some of these women. And not only is the number one reason for maternal mortality, but 2/3 of these pregnancy-related deaths are considered preventable. So we are starting this initiative because we think that it's incredibly important for the women out there. It leads to obviously better outcomes. In addition to that, it is worth noting that these patients many times have things that won't kill them, like preeclampsia or gestational diabetes or gestational hypertension. We know that even though that tends to pass when the baby is delivered, the truth of the matter is that these women are at risk for hypertension and diabetes in the future as well, and they need to continue surveillance in order to monitor them and treat them as necessary. So we think that that's hugely important, and we have one of our physicians, Dr. Imbar Saporta, actually, who has specialized in this, and she will have the support of Dr. Casanova as well in Miramar. And I would urge you, if you are pregnant having any issues, or if you had gestational hypertension or diabetes, to please schedule an appointment with one of those physicians, because we want to continue monitoring you and make sure that you don't acquire those conditions later on in life.
Thank you. Dr. Chukwu?
Yes, this is a very important topic. These days, I see a lot of patients where the women have chosen to have children a little bit later in life. And with that decision comes the possible use of assisted reproductive technology, which can be in the form of in vitro fertilization, using an egg donor, sperm insemination. So with all these things, there was actually a study that was done last year, it was published, and it took a look from a national institutional sample, and they looked at 46 million births. And out of that, with the slightly over 100,000 deliveries, they compared data from, say, 2008 to 2019, and the ages of about 35 to 28, and those two groups of women. And what they looked at is that they found that there was an increased risk of cardiovascular complication from the group of women that use the assisted reproductive technology. And what they found out was that group of women, they saw increased risk of preeclampsia, about 48%. Those women were 2 times as likely to have congestive heart failure, 40% likely to have irregular heart rhythms. This was alarming data. And yes, one can argue, well, as a woman gets older, she may have increased comorbid conditions, more hypertension, more diabetes, more high cholesterol. But even after they corrected for those factors, it was still at an increased rate. So it just goes to show that it is really important that one has that conversation with patients so that their risk can be as low as possible from the beginning, meaning making sure that you plan ahead before you move forward, making sure that the blood pressure is very well controlled, making sure that the cholesterol is very well controlled. These modifiable risk factors, make sure you have that conversation with your doctor to be very well prepared before you take those steps where the complications are very real and they can occur. So it's just very important to have the conversation with the doctor, be aggressive in your healthcare management, and we'll see how things go in the future. More research does need to be done.
Thank you for that. And I'm going to take 1 second and read a couple. I have two more questions we're going to answer from Facebook. And I think we're wrapping up, guys. We've been here and the docs have to get back to work. But, and I'm sorry, I'm hearing a little bit of feedback on the line. We're going to try to fix that. A question. When should you see, at what age should you see a cardiologist and do a stress test?
Me?
Sure.
I guess. So I think the important thing, as Dr. Chukwu mentioned before, I think that going to the primary doctor is always important because they are really the gatekeeper and they kind of decide whether it's necessary or not. If you don't have a primary physician or you prefer to see a cardiologist, I would think that the reasons to see us, one would be symptoms of concern. If you're having shortness of breath that you should not be having, I'm talking about huffing and puffing or panting. If you're having chest discomfort, if you're having an uncomfortable feeling in your heart that your heart is beating too fast, that is called palpitations, or if you have had a dizzy spell or a fainting spell, those are appropriate reasons. If you have a family history for premature coronary artery disease, for premature heart attacks, it is also very important, particularly if you have associated conditions such as high blood pressure, diabetes, or high cholesterol. It's important to see us. Now, in terms of the second question, it's funny because everybody wants to have a stress test, and yet for most people, a stress test is not really necessary. We do stress tests when somebody has symptoms like I just mentioned, shortness of breath, chest discomfort. For most people, what we do is we calculate the risk of having a heart attack and we decide whether any intervention is necessary, meaning the use of cholesterol-lowering medications such as the statins. For most people, it's just an issue of treating the blood pressure or diagnosing a rhythm problem in the heart. Stress tests, we used to do a lot of them before, but we discovered they didn't move the needle one way or the other. They're really important in patients with certain conditions, what problems with the heart valves, for example, or problems with symptoms such as the ones that I mentioned before, chest pain, shortness of breath, that kind of thing.
Thank you for that. And I know we have a couple of additional questions. So to our viewers, whatever we can't get to right now, we will share with the docs and we will either send you a private message or we will answer it on our comments below. Because I want to leave room for one last question, which is, and to me, it's the most important. Some of us have already had a couple of issues with like cholesterol or something else that has come back a little bit abnormal. If we take charge of our heart and we do some of these things that we've talked about, um, can we reverse the heart health? Can we get better?
Absolutely. If we take charge of our health, we can definitely move the needle and reverse our risk of coronary artery disease. We mentioned earlier how it's really important, say if you're age 20, your blood pressure is running under 120/80, at least see the doctor. Get things checked once every 2 years. Now, if the blood pressure is running higher than that, it is essential that you see your doctor more frequently than that, minimally yearly. These things are very important. Additionally, make sure that you're having that heart healthy diet in terms of avoiding saturated fats, avoiding trans fats. Try to make sure that when you are exercising, you're getting to that target heart rate, speed walking, breaking a sweat. Remember that number, 220 minus your age. Make sure your heart beats 85% of that number and maintain that for about 30 minutes so that that good cholesterol will be raised to 60 and give you that cardiovascular protection. These things are things we can take control of. You can reverse the needle. Remember, the studies did show if you decrease that cholesterol amount by 10%, you can decrease your risk of coronary artery disease by 30%. So every little bit counts. Every little bit helps. Let's work together to achieve that goal.
Thank you, Dr. Levy.
Yeah, thank you for your question. I think that's perhaps your most important question, Janet. And I think it goes to my two favorite things. Number one, as Dr. Chukwu just said, a partnership with your physician is the most important thing. I consider my patients partners with me in their health. I'm their healthcare advocate, and we make decisions together. And if we are both committed to reversing or preventing any cardiovascular consequence of many of the issues that we may face, we absolutely can move the needle back and be healthy. As a matter of fact, my second observation would be that I teach my students or my residents, my fellows, that when I ask them, what do you see your role as a doctor? And I think my role is a little bit different. What I explain to them is, yeah, sure, I can treat high blood pressure, I can treat, coronary disease, heart failure, whatever it is. But my role, my most important role, is trying to normalize people's lives. I want people to feel that after we do whatever intervention, or if we decide on a medical routine together, that once they spend those 30 seconds a day taking the pills, they have completely normal lives. They can go about their routines, they can do their jobs, they can spend time with the family. And if I'm able to achieve that, I think that I've succeeded as a physician. So not only is important to take charge of our heart health, but it's also, and we can move the needle back, but it's important to understand that my role is to make it easier for you to have a normal life without having to worry about cardiovascular consequences of different conditions. And if I succeed in doing that, I'll be very happy.
Thank you so much, Dr. Levy, and thank you so much, Dr. Chukwu. This leads us to the end of our Facebook Live. I want to thank you both for your time and for your expertise. And as I mentioned earlier, we'll get to some of the questions that we didn't get to. But thank you so much for talking to me and to all of our viewers about our heart health. Thank you so much.
Thank
My
you, guys.
pleasure. My pleasure.